Greetings to all our viewers. I welcome you all to yet another session of PhysioTV Classroom. I am Dr. Mudita Chavan. I am an assistant professor in the Kinesiology and Kinesiotherapy department at Sancheti Institute for Orthopaedics and Rehabilitation, Pune. So in today's PhysioTV Classroom, we are going to look at the structure and function of diaphragm. Okay, this topic would be really helpful for the undergraduate students to understand what exactly are the parts of diaphragm and how are they involved in the process of breathing. So let's start with the topic. So diaphragm, structure and function. So the objectives with this session are going to be to understand what are these different segments of diaphragm, to understand what are the origin and insertion of all the segments that we are going to study about of the diaphragm, to understand what is the function of these segments during breathing, and finally a quick look or a glance at what diaphragm dysfunction might occur in a chronic respiratory disease. Introduction. So as we all know, diaphragm is the primary muscle of ventilation. About 70 to 80% of the inspiratory force or inspiration that occurs during quiet breathing or tidal volume breathing occurs with the help of diaphragm. So the muscles or the striation or the orientation of the muscle fibers are in circular fashion, and these fibers arise from different landmarks like the sternum, the ribs, and the vertebral bodies. As you can see, these fibers, they run vertically and goes in the superior direction, and then you can see that they are inserting into this whitish or pinkish structure in this diagram, and this structure is known as the central tendon. Okay, so this is what makes a diaphragm pretty unique, is that as compared to the other musculature in our body, diaphragm does not have any bony insertion. That is, it does not insert into any bony structure. Rather, it inserts into the tendon, which is the central tendon, making it pretty unique in our body. So now let's look at what are the segments of different segments of diaphragm. So broadly speaking, functionally, the muscular portion of the diaphragm is divided into uh, dorsal segments and the ventral segments. So dorsal segments, as the name suggests, these structures, when a subject is standing upright, these structures lie anteriorly, and then there are the ventral segments which lie relatively posteriorly to the dorsal segments. So the dorsal segments are the segments which arise from the sternum, from the xiphoid process of the sternum, to be more precise, from the ribs. Okay, so this is the reason why the dorsal segments are also known as costal fibers. Okay, because ribs are also known as costals. So these structures arise from the ribs, which is why they are also known as costal fibers. Then we have the ventral segments, which are these. These structures arise from the vertebral bodies. So that is why lying ventrally, and they are also known as the crural fibers. We'll understand in the consecutive slides why these structures are known as crural fibers. So looking at the diagrams, so this is the sternum, this is the xiphoid process. These are the ribs that you can see. The lower 6 ribs are from where the diaphragm originates for the dorsal segments bilaterally, and then there is the xiphoid process. Okay, so this is the right dome of the diaphragm, this is the left dome of the diaphragm, and this white structure that you see is the central tendon. Okay. Similarly, this is just the posterior view of the diaphragm. So from the posterior angle, these are the vertebral bodies, and this pink structure that you can see is again the diaphragm. Okay, moving on. So let's look at each segment in much more detail, starting off with dorsal segments. So like we saw, these segments are also known as costal fibers because they originate from the xiphoid process, that is the posterior aspect of the xiphoid process, also known as xiphisternum, and from the lower six ribs, which is why they are known as costal fibers, and also the costal cartilages. Okay, so the costal cartilages of the lower six ribs is from where these fibers or these segments arise. Again, as you can see from the picture, they run vertically in close approximation or apposition to the rib cage. Okay, so after running vertically, they then turn horizontal and insert into the central tendon. Okay, so this area where the fibers are running vertically in approximation or in opposition with the rib cage is known as the zone of apposition. Okay, so we need to keep this zone in mind. While because this zone, it's what comes majorly or plays the major part in breathing. Okay, so this is the zone of apposition. This is just the inferior view of the diaphragm to better understand what we just studied. Okay, so this is your xiphisternum and this is your vertebral column. So your dorsal segments or the costal fibers, they arise from the xiphisternum or the xiphoid process from the lower six cartilages, costal cartilages, and the lower six ribs. Okay, both on the right side and the left side. Okay, so this picture shows some additional structures as well. As you can see, there are these vertebral bodies L2, L3, L4. Also, there are these openings into the central tendon, which is one is for this inferior vena cava, one is for the esophagus, and this opening is for the aorta. Okay, so what we need to remember is we are looking at the dorsal segments. Okay, so these are the dorsal segments or the costal fibers of the diaphragm. Let's move on to the ventral segments now. And as we saw, these segments are also known as crural fibers. Let's understand why they are known as crural fibers. Okay, that is because they originate from two tendinous structures, which is the right crus and the left crus. Okay, so this is majorly why these fibers are known as crural fibers as well. Okay, and they also originate from the aponeurotic arcuate ligaments. Okay, let's understand what each of these structures mean. So this is the right and left crus. Both these tendons, they arise from the L1, L2, L3 vertebra, and they run ventrally and medially. Okay, so ventrally as in slightly anteriorly, and they meet up, join together at this region, which is just ventral to the aorta. So this is where the aorta comes out of. Okay, this area is also known as the aortic hiatus. Okay, so this is from where the aorta runs out of. So now let's look at the aponeurotic arcuate ligaments. Okay, so the aponeurotic arcuate ligaments is divided into two, that is the medial arcuate ligament and the lateral arcuate ligament. Okay, on either sides. So the medial arcuate ligament, it runs upper and over the anterior surface or anterior part of the psoas major muscle. So this area is from where the psoas major muscles runs out of. Okay, so it starts or extends from the L1 or L2 vertebra, and it inserts into the transverse process of either L1, L2 or L3 or into the 12th rib. Okay, so that is the medial arcuate ligament. Looking at the lateral arcuate ligament, it originates or it starts from the transverse process of either L1, L2, L3 vertebra, and then it inserts into the 12th rib. Okay, so it starts from the transverse process of the L1, L2 or L3 vertebra, and then it goes further and inserts into the 12th rib. So it is much laterally placed, which is why it is known as the lateral arcuate ligament, and this is the medial arcuate ligament. This is for the right side. the left arcuate ligament, medial arcuate ligament, and the left lateral arcuate ligament. Okay. So now that we've understood what are the segments of these fibers of the diaphragm, we need to understand how they function during breathing. Okay. So during tidal breathing, what happens? So during tidal breathing, the zone of apposition. So this was the zone of apposition which is formed by the costal fibers or the dorsal segments. Okay. So these muscles or these zone of apposition that is there, the vertical running fibers, they contract when there is a inspiratory force that is to be generated. These vertical fibers are the ones which contract, and because of the contraction of these vertical fibers, the horizontal dome of the diaphragm slowly descends down, making more space for the thoracic cavity to take up the inspired air. Okay, so with the descent of the dome of diaphragm, there is only slight change in the curvature, not much change with the curvature of the diaphragm. And because of the descent, the abdominal contents are compressed, which increases the intra-abdominal pressure. Okay. So this is a video showing how the tidal breathing occurs. So these vertical running striations of the muscles is the zone of apposition. So once these muscles contract, the dome of the diaphragm just descends downwards, making more space for the lungs to breathe in and for the greater inspiratory force to be generated. So now let's understand what happens with deeper inhalation. So with deeper inhalation, as we saw with the zone of apposition, the abdominal contents have been pushed downwards and been compressed. Okay. So there is no further space for the abdominal contents to move, which leads to the stabilization of the central tendon of the diaphragm. Okay. So because of the continued contraction of the costal fibers of the diaphragm, there is against the stabilized central tendon, there is now lifting and outward rotation of the lower ribs. So this lifting and outward rotation of the lower ribs leads to the bucket handle motion that we see in the ribs. Okay. So let's have a look at a video showing the same. So here you can see that the diaphragm has descended, but at the end of the inspiration, even the ribs are being pulled out into the bucket handle fashion. Okay, so it is these fibers which are pulling the lower ribs outwards, okay, and upwards to make more space for inspiration. Next. So, crural fibers of the diaphragm. So, we saw about the zone of apposition and the costal fibers. What about the crural fibers of diaphragm? What is their role? So, crural fibers of diaphragm, they have an inspiratory effect on central tendon of diaphragm, but they don't have any direct effect on the lower ribs as such. Okay. So, because of the action or the contraction of crural fibers of the diaphragm or the ventral fibers or ventral segments of the diaphragm, there is the descent of the central tendon. So, it helps again or augments the descents of the central tendon, and this in turn helps or puts increased pressure on the intra-abdominal contents, and the intra-abdominal pressure is increased. Okay. So once again, like we saw in the previous slide, because of the increased pressure that is again transmitted because of this function, increased pressure which is transmitted across to the opposed diaphragm, again these two indirectly help to pull the ribs outwards and upwards. Okay. So they augment the costal fibers of the diaphragm to expand the lower rib cage as well. So as we can see once again in the same video with much more clarity, the crural fibers, again with their contraction, they will pull the central tendon downwards or the dome of the diaphragm downwards, but because of that, it will increase the abdominal pressure, intra-abdominal pressure, and this pressure is further transmitted to the opposed fibers of the diaphragm, which will help to which will help the costal fibers, that is the opposed fibers, to pull the ribs, the lower rib cage outwards and upwards to create more space for inspiration. So now let's look at thoracoabdominal movement. This movement is something which occurs in accordance with the inspiration or the breathing. So what happens is these are the abdominal contents. Okay. So during quiet inspiration, because of the pressures that are generated due to the contraction of the diaphragm, there is the thoracoabdominal movement that takes place. So when the diaphragm contracts, the central tendon or the dome of the diaphragm, that is also descending downwards. Okay. But accompanying this is also the increased intra-abdominal pressure. Okay. So because of the descent of the diaphragm, there is added pressure onto the abdominal contents, which increases the intra-abdominal pressure, like we just saw. So, because of this increased abdominal pressure, the contents are going to be displaced forward or laterally. This is a video just showing that. So, once the diaphragm comes forward, the abdominal contents or the abdomen is being pushed forward, and the contents inside will also be pushed forward or anteriorly as well as laterally. What happens once these muscles which have contracted, or the segments of the diaphragm that have contracted, once they relax? So once the active muscle contraction of the diaphragm stops or ceases, the domes, as you can see in the video as well, the domes also come to their resting position into the thoracic cavity, which is going to decrease the thoracic volume. Okay, so the thoracic volume decreases as well. So since the volume has decreased, the intrapulmonary pressure are going to increase, and there is spontaneous exhalation that occurs. Now the intra-abdominal pressure is relieved, because of which the intra-abdominal pressure are going to reduce, and the abdominal contents are going to return to their starting position. And that is how the entire cycle of breathing takes place with the help of the diaphragm. Now, a quick look or a quick glance at what happens in diaphragm dysfunction. So, just a quick example would be chronic obstructive pulmonary disease. So, as we all know, there is, because of the chronicity of the disease and the hyperinflation of the lungs because of the air trapping, there is going to be the diaphragm is going to be placed much lower than it ideally should be. So the resting position of the diaphragm is in itself in the lower part of the thorax. More severe the disease is going to be, the flatter and more lower the diaphragm is going to be. So because of that, the zone of apposition that we saw, the vertical fibers that are running in the costal fibers or in the dorsal segments, they themselves, rather than being vertical, they are going to be more horizontally placed. So the area that they have to contract is going to be reduced. The active contraction of the diaphragm, which is already flattened with not having much area for the zone of apposition to work, rather than pulling the ribs outwards and upwards, which should be the ideal way, it will end up pulling the lower rib cage or the lower ribs inside inwards, which will in turn decrease the thoracic size and also make the diaphragm ineffective to be used. Let's just have a look at an X-ray of COPD. So you can see here, this is the diaphragm. The dome shape not present. The fibers are horizontally placed. So as we saw, the zone of apposition is considerably reduced here. So since the zone of apposition is reduced, the thoracic cavity is already expanded and hyperinflated. So the diaphragm is at a disadvantage, because of which it is going to be ineffective or not going to contribute to breathing very well. So let's just quickly summarize the segments of diaphragm. So we saw that there were two major segments of diaphragm, that is the ventral segment and the dorsal segment. Dorsal segments are also known as costal fibers because they arise from the sternum and the ribs, the lower six ribs, and the costal cartilages. And the ventral segments, which arise from the right crux, the left crux, because of which they are also known as crural fibers. Okay, so we saw the origin and insertion of it. They finally end up inserting into the central tendon, which makes diaphragm pretty unique because the insertion is not into any bony structure as compared to other musculature in the body. Function, so this costal fibers, as we saw, they have the zone of apposition, which helps to descend the diaphragm downwards. And then there are the fibers which are present at the periphery, which help to open up the lower rib cage by moving the ribs outwards and upwards, okay, in the deep inspiration phase. And the crural fibers, they just contribute to bringing or contracting the diaphragm downwards, so pulling the central tendon or the dome of the diaphragms downward, but not directly contributing to the expansion of the lower rib cage. Then we looked at the thoracoabdominal movement during breathing. So just as we saw, the pressure in the thoracic cavity is going to decrease, which is going to allow for that inspiratory force and increased inspiration, while the increased pressure of the diaphragm into the onto the abdomen is going to increase the intra-abdominal pressure, leading to the abdominal contents to be pushed anteriorly and laterally. Then finally, we ended with the dysfunction of diaphragm, how it can dysfunction in chronic respiratory diseases, because for a disease like chronic obstructive pulmonary disease, fibers in the zones of apposition, they are going to be placed considerably horizontally as compared to how it should be in a healthy individual, that is vertically. So since they are already at a disadvantage, the diaphragm ends up being a ineffective structure to help out in breathing. I want to thank you all for listening in. I hope this was informative, and I hope this helped you to understand the joint structure and function of the diaphragm better. Thank you for listening in, and I hope to see you all again in another session of Physio TV.